And welcome back, y'all. How was the break? I, for one, miss all of you, and I miss all the good times we've had together. But like someone once said, wise one said, speaking is hard. If you love something, set them free. And if they return, well, now I'm getting a little too mushy. So let's talk about something else. Let's talk about hematology and oncology. Hemonc is a gigantificated specialty that covers a whole lot of disease conditions and treatments, both surgical and office based, which can keep experienced coders busy with a lot of work. So let's cut my preamble short because we need to get to all the key discussions and introduce our panelists. Tonight we have three panelists. We have Stephanie the Barge. I didn't introduce you as El DeBarge, like I was avoiding. Is the compliance manager at the New England Cancer Specialist, as well as a member relations advisor for the AAPC National Advisory Board. She is also the owner of Sea Coast uh, Coding Compliance Specialist LLC.
Yeah, it's close enough.
I messed it up. I always do that.
It's a long name. It's my own fault for naming it such a long name.
And Stephanie will be discussing her daily routine and managerial coding role in hematology and oncology. And we have Alexis Isom, who is a provider educator and Chonk certified coder, as well as an AAPC subject matter expert in oncology. And she will be discussing her role in the clinical aspect and expectations for productivity and skill set from her perspective as a clinically oriented coder and educator. Rachel Williford is the senior coverage and reimbursement specialist for the American Society of Clinical Oncology, which is like the National Association for Clinical Oncology. Big group, big subject matter expert. And is that being said, is evidence of her skill set in oncology coding, and she'll be talking about advancement, skill set requirements, and how to improve yourself as a coder in this specialty. So we've gone through all of that, and I didn't butcher anything too much. So let's get started with hematology and oncology. What is the difference between hematology and oncology? Let's start with Stephanie.
Well, hematology is the study of blood and blood disorders like anemia, bleeding disorders, hemophilia, blood clots, blood cancers. That's kind of falls under hematology. While oncology is, again, the study of cancer. So we're talking about all the different types of cancers. And then within that oncology, there's like three major areas: medical oncology, radiation oncology, and surgical oncology. So, in a nutshell.
Mm-hmm. All right. Alexis, is there anything you want to add to that?
I totally agree with Stephanie. That's probably covers everything. Hematology just really focuses on like blood issues. So like Stephanie said, the anemia, maybe MDS, patients who need blood transfusions for various reasons. And then oncology is like the world of cancer, everything cancer related.
And Rachel, how would you add in your portion?
I agree with everything these two ladies have said. I would say that there's a lot of overlap because there are a lot of side effects from oncology that are hematology related and vice versa. And so a lot of oncologists are also hematologists. And a lot of them practice both sides.
Mm-hmm.
Okay. So if anybody, could work in hematology and oncology, they can pretty much keep themselves occupied for a very, very long time. Or even if it's split up, is there still a lot that someone could be kept occupied with?
Yeah, I think so. From a coding aspect, it depends on how you're hired, I would say, because if a coder is hired to focus on E&M coding, that's going to look a little different versus if they're hired to focus on infusions, chemotherapy, that kind of thing. A lot of departments kind of split it up. So you may have issues, or not really issues, but areas where it's carved out. The infusion coding sometimes could be a beast all on its own. So that usually gets its own work queue, its own set of folks to, focus on that. So I think there's enough work in both areas. It just really depends on what you're hired for, I think.
Anything you ladies want to add on to that?
No, I think Alexis did a really good job at explaining that. Like she said, it really depends on the practice and how the roles are delineated.
Yes, I agree as well. Yeah, it really does depend upon how you break up that coding that you're going to be working on. And is it just E&M, or are you really working on those infusions? Hematology, I think, is definitely a lot easier as far as there's not, a lot of people are getting injections and things like that, which are easier to code as opposed to somebody getting numerous cancer drugs and compounded cancer drugs for their cancer. So, but definitely there's so much overlap. That's why most coders that work in this arena are doing both hematology and oncology.
Mm-hmm.
Yeah, which is why they call it hemonc. I mean, it's like they're like fused together. But I've never seen one person that was just oncology or just hematology, or vice versa, just oncology or just vice. I already said that, didn't I? I did. So let's talk about some of the disease processes that you treat in hematology and some that you treat in oncology. I know cancer is a big one, but let's talk about what some of the things you commonly see, like in your daily practice.
Well, I could start. Our providers are broken into teams, so they have a lot of there's different teams that focus on different specialties within oncology. So it's not just or hematology. So we have you have your heme team, which deals with a lot of the heme factors, all those things that we were talking about, all the hematology issues, the blood disorders, the blood cancers. That's what the heme team works on. Then we have the breast team. Guess what they do? They primarily work with the breast and all the breast cancers or lumps and nodules and things within that. Then we have a solid tumor team that works on solid tumors that these providers work within, maybe just lung, the prostate, testicular, bladder, kidney, those kind of diseases. And then we have like the head and neck that do like a more let's just say brain, like your glioblastomas, things like that are more complex and possibly terminal. So not that all cancer is probably possibly terminal, but it's just a lot harder, I guess, with that. But that's like within oncology. And then under oncology, there's also, with all these teams, you also have to have that supportive care team, the team that's going to take care of that patient, talk about their advanced directives, have those, harder conversations about their supportive care meds and hospice. When is it time to go to hospice care? So what else did I miss?
Alexis or Rachel, anything that you want to add about some of the things you would see, disease-wise in?
Sure. So when I was in practice, we were a community-based clinic. So our doctors really didn't specialize. They saw everyone, everything. Our providers tend to have a focus that they like to see, but we didn't really have teams. But we also had pediatric and sickle cell, which is common for hematology. Leukemias, lymphomas, which are interesting in the pediatric setting because it's treated completely different than your adults. That having never dealt with pediatrics before, that was a real eye-opener. And like I said, the treatment plans I had never even heard of. So you're definitely always learning. Hemophilias, von Willebrand's disease. You see a lot of anemias in both oncology and in hematology. All the penias. Basically pancytopenia.
Yeah.
Thrombocytopenia.
Yep. So just because you see something in hematology, a lot of times you see the penias because of treatment. So you also have to be able to look at that. But then some of the things that I saw, because they would go to hospitals, you see the typical stuff that you would see in a hospital or an inpatient that complicate the cancer treatment. So it's not always just oncology and hematology. You see kind of running the gamut. So it's very interesting.
Yeah, I agree with both of the ladies. The wide variety of patients' conditions that we see could kind of be almost endless. Crohn's disease is another big one that we tend to see a lot, because a lot of patients with Crohn's will come for infusion therapy. They may be following up in the same department as like oncology, hematology, even though that's not, let's say, a cancer diagnosis. So I agree. There's just a full range of different conditions that are often lumped in with hematology oncology.
Okay.
Totally agree there, because we have a lot of non-oncology infusions as well, and those are patients, like you said, for Crohn's or different disorders that are coming in, like for their MS, so that their neurologist might have sent those patients in, or gastrointestinal, the GI doc's going to send them in to be seen. And why we're doing it in practices that are private, like private practice or community oncology practices, is because of the low cost to the patients. So again, keeping that cost down, going to the hospital and having treatment there can rise, bump up patient costs. So as a coder, if you're going to be coding the specialty, you might be doing those kind of, even though you don't expect, oh, well, this patient with MS, I know I have to code for that, and I have to code for that infusion, and what do I need? What are the diagnoses I need to put on there? So there are things like Alexa said, that definitely opens it up.
Mm-hmm.
All right, so I don't normally talk about a lot of high technical specifics about coding. I tend to talk about like what's like on a daily basis, but I have to get into ICD-10. So in oncology, ICD-10 doesn't follow the normal kind of formatted structure within the ICD-10 manual. Sometimes it's very hard to find the right diagnosis codes. Can we go over the process of that? I know me and Rachel were actually going back and forth on this a lot earlier, but let's talk about the process for finding diagnosis codes in the ICD-10 index. Rachel, you want to lead off with this one?
Sure. So normally with your ICD-10 codes, you're going to go to the index, right? Well, instead with oncology, you're going to a table, which like it baffles the mind, but you go to a table to see where, and that's when the anatomy and physiology knowledge really comes into play. You've got to know your body systems, what falls under what, because it's not necessarily going to come out and say bone.
Mm-hmm.
They say like a sarcoma. So medical terminology, anatomy and physiology, very important. And that's, I think, something more than a lot of other specialties. And it's not just one system. You have to know all of the systems, because cancer can be anywhere in the body.
Yeah, so I believe the table is actually divided further. It's by anatomy, but it's also by type of cancer too, right?
Yes.
Mm-hmm.
Yes.
Primary, secondary.
Primary, secondary. Another thing is that it's not, where was my thought? So it's not always like what you may see in documentation isn't necessarily what you see for a diagnosis. Like what we typically consider like pertinent information in our everyday lives, not necessarily coding, but let's say a cellular type, whereas like pathology is very focused on cellular types, and what it is, the site location of where that cancer is, not necessarily what type of what cellular type of cancer it is.
And sometimes even with that, you might have a pathological stage and a clinical stage. So there might be different stages of these cancers. And when I talk about that is that, you know, our providers, sometimes there is no pathology. Sometimes there's not a path. Maybe it's too risky for the patient to have a biopsy. So they're using their clinical judgment, their best judgment. What does this patient have? Now it can be cancer, it can be something like MDS, you know, and it's just, again, based on the labs, based on the information, they are making their best decision, best diagnosis, which is always for a coder. We're all like, I don't like probable, don't use probable, don't use, you know, likely, don't use any of those, you know, terminologies, but they have, you know, based it upon multiple tests and multiple reasoning that this is what it is. But that's some things that to be aware of when you are coding. That's always a little bit of an issue. And then don't get me started by history of. I don't even want to go down that road. Well, there's so much with history of coding issues. Oh my goodness. No, when to mark a patient history, when to not mark a patient history of. So.
I know on the table neoplasms, which I think is what they have in that the index, they have it broken down into what behavior is. But there's like malignant, there's benign, there's what's the one? There's in situ, there's and there's unspecified behavior and uncertain behavior. Mm-hmm. So would you say that, like, if you don't know if it's malignant or if it's benign, would you use uncertain or unspecified? Because I always mix those up. You know,
it depends on the documentation.
I was gonna say the same.
It depends on how it's documented. If the unspecified is for when the documentation doesn't show what the cancer is, like if they just say cancer, metastatic cancer. Well, you're not specifying the cancer. But if pathology can't tell what it is, that is when it's uncertain. And it is specific. They have to specifically say it's of uncertain diagnosis. Mm-hmm. That's a pathology versus documentation.
Yeah.
Because I think that's important to know, because when you look in the index for, like, you know, if you look up cancer and you say, let's say lung cancer, and you look in the index for cancer, lung, you follow the hierarchy, sometimes it'll point you to malignant. But it might not be supportive. You know, we're trained as coders to follow the, you know, the index to point us where the code is. Well, sometimes the index isn't the best place to start. So how do we know if we're coding correctly? If two different indexes point to two different ways, like the index in the alphabetic index points us to malignant, but the documentation doesn't support it, and we have the whole grid to use. Well, what do you say about that? Because I've seen that too.
I would say if a patient is in for cancer treatment, so like based on what they're having done on that data service, and we see that they're coming in for something like chemotherapy, for example, and the physician is not clear in their documentation, in most cases with this type of role, you will have some ability to query the provider. At least you should, at least maybe a nurse or a PA. And I think that would be the best route, because you definitely wouldn't want to assign a diagnosis code that's not accurate for something so serious as a cancer diagnosis. And then you also want to be able to get it right, because if a claim is submitted with certain drugs on the claim and the diagnosis is not there, it will definitely get rejected. For the highly complex drugs, they have certain edits in place with like insurance companies. It'll bump it out the system automatically. So I would say, when in doubt, for sure, query. And this role with like hematology, oncology should have some type of provider interaction or even managerial. They can route those questions up to the right party.
Now, I know there's other kinds of cancers that don't make it to the table of neoplasms. Can we talk about some of the odd ones, like the neuropseudoendocrine tumors and all those weird, funky ones that sometimes that just really throw us off? Because I see a lot of that, and I'm like, is it a neuroendocrine tumor? Is it, cardiopodiatry? What, I don't know. what it is. There's so many different things to look up. And then there's indication. No, it's like there's classifications like T1, N0. What do those indicate? Yeah. Well, that went out of nowhere.
Yeah. Yeah, I mean, neuroendocrine tumors are so hard, I think, too. Like the documentation, again, will support it if it's a like, again, there should be some documentation from the provider saying this is neuroendocrine versus not. Those are very complicated disease pathways. When you see the TN, all that stuff that comes after, that's staging of that cancer. So that's talking about where the patient has the cancer and if it's spread to different areas within their body. And sometimes they'll say, is it HER2 negative or HER2 positive or ER positive? There's so many different things come back when it's staged, when they take that biopsy, put it under scope, and then they give you a nice report and says, this is all the stuff that's going on. And usually, like I said, right in there, we'll tell you, what is this? Is this a carcinoma in situ? Is it a benign? Maybe it's not. Maybe it's just a lump in the breast that they have to monitor. But there's just all that information is in the pathological staging. But the TM1 scores are definitely, that's where they're looking at that, and more. I think a lot of our documentation goes out to these insurance companies. They want to see the staging. They want to see, they're looking at that for how to pay and how to, how sick are these patients and how advanced is this cancer. Because that's ultimately, they're not going to let you do a second line treatment on a patient. And when I say it, that means that they have to try the first line treatment first. And so they need to see where you're at. Just because they're metastatic doesn't mean they're automatically qualified. So there's a lot of, like Lex was saying, with claims and authorizations that can throw you into a whole other process.
Well, and I was going to also add that a lot of times I wouldn't say it's extraneous because it's very pertinent. Like Stephanie said, it's you want to know what the mutational mutations are, especially with lung and some of the other processes. But mutation and tumor mutational burden and PD-L1 status but when it comes to diagnosis coding, all of that has no bearing on the actual code.
Right. Yeah.
It's site and location.
Exactly.
And you got to break it down to its simple basics.
Right.
So can we talk about the scary term metastasis? So I've seen this a lot, and I've seen it very lean in how it's documented. There'll be in the patient in the plan of care or in the assessment, will say metastatic lung cancer. So does that mean that it was a primary lung cancer that went somewhere else, or was it a primary cancer somewhere else that went to the lungs? Sometimes it's like industry standard that we should be thinking about. Is that what's the proper terminology for metastatic lung cancer? Does that mean it's where that began, or is that where it is now? Because I always have a hard time with that.
We have a hard time with it too.
Usually it's where it begins, but if it's most of the time it's where it begins. So that they have lung cancer, that's to somewhere else, and usually you're going through the documentation. Well, where is it? Where is it? Where do they have it? Well, they said metastatic. I know it's metastatic. But you might only have lung cancer as a diagnosis on your claim, when the claim comes through. So again, looking for that documentation to find where is it metastatic to.
Mm-hmm.
And sometimes it's about educating the providers and saying, you're saying this, but I need you to be clear so I know where it originates and where it's spread to, because that determines how I code it. Because 100%. Providers are not coders, and they don't always understand what we need to see. And it really depends on how they word it and knowing clearly where it originates and where it's spreading to. And it's important to know that.
Yeah, I mean, it's always something I'm looking for. And I guess querying is is the best solution, or just overlooking completely. You know what? Let's not even code this. Let's skip it. We'll just say that they have leg pain. All right, so let's just skip away from diagnosis because that's giving me a little bit of a headache. But let's talk about E&M services and office coding. What are some of the usual treatments that you see in the office besides E&Ms? And how should people prepare to see them? And how should any coder how should a coder prepare themselves to understand what's happening in these kinds of situations?
Well, I'll start. Oh, sorry, Stephanie.
No, go ahead.
Aside from the E&M, like we sort of touched on a little bit, it's going to be mostly the infusions in this area. So with cancer treatment specifically, a lot of times patients are coming in for multiple rounds of chemo, or they have a certain plan or a regimen. You might see your same patients on like a continuing basis. You'll notice certain names will come up frequently. A lot of the regimens are long chemo treatments, so that's where like that hierarchy and CPT coding comes in. So to prepare for that in this role, I think a lot of this infusion coding portion is going to be training. I know like when someone first starts out in hematology, oncology, they need kind of a lay of the land. So someone more seasoned who's already maybe been in the department to kind of show them how things run, especially like with reports or however the system generates the log or the patient list for what happened the day prior. So I think aside from the E&M, it's really going to be the infusion focus. And I would say that a new coder would probably need someone in the department to kind of show them how that goes. A lot of people are typically confused by infusion coding. So someone who kind of knows how to train another coder on that would probably be the best solution.
I heard there was math involved with infusion coding. Is there a lot of math? Because if so, I'm out.
No, it's not math, but it is time.
There is math.
There's math.
You're adding time, so yeah, you're adding time.
Math, time, and milligrams.
Yeah.
Milligrams,
and that's
grams.
if you're coding drugs. So depending on how sophisticated your system is or like the place that you work for, you could be left with coding drugs, which is, I think that would be like a whole other conversation. But yeah.
Yeah, and just to add to that, there are some procedures that we do in the office. Bone marrow biopsies are big, like we have to biopsy in order to know the plan. We might also do lumbar punctures and therapeutic phlebotomies and paracentesis and thoracentesis. Those are done in like the hospital outpatient side, but they do those a lot. And that's when they take fluid out of the abdomen wall and trying to reduce that fluid because the cancer is not preventing it. What?
I was also going to say there, depending on the practice, you might see imaging, PET scans, X-rays, DEXA scans. Really and truly familiarizing yourself with the different chemotherapy names gives you a leg up on a lot of people. Just drug names. And like I said, pediatrics is completely different than adults. But also, it's important to know that this is a specialty that is coming under more and more scrutiny just because of the cost of treatment. Familiarizing yourself with policy is big, because just simply knowing whether or not a drug is a preferred drug can save thousands upon thousands of dollars for a practice. So policy, drug names, infusion. John looks overwhelmed.
Well, You mentioned PET scans, and I know that's a big headache of mine because I think Medicare just revised their policy on PET scans, and it didn't really clarify anything at all. It's still it's kind of vague. Is it covered? You don't know. I don't know. Possibly. Give it a shot. Try us.
And if you're in radiation oncology, there's a whole other, and now you're coding, having SIMs and things, like we're med-onc mostly at my practice, and we're going to be starting in rad-onc too. So I'm learning, again, learning all about rad-onc and how that's given. And it does seem simple because there's not too many different, options, but definitely you got to read all those policies, those guidelines. I've been reading like crazy, like learning all about the different everything that goes into radiation oncology, and trying to, again, knowledge is power. Just get onto those network groups, things that I can find that people are networking about it, talking about it, so that I can just kind of immerse myself in something that I might be unfamiliar with. Now, I could tell you all day about drugs and infusion and all that stuff, but when we talk about radiation, it's a whole other beast. So it's just, again, understanding that and where you're at, what kind of coder you're going to be for your company. Are you just reviewing the documentation, or do they already the software come through with all the codes and you're just reviewing? Do I got to add diagnoses? Do I have to add modifiers? Do I have to look, is that the stuff that, just to make sure that the software didn't miss anything, miss any infusion or hydration or anything that should have been coded or shouldn't have been coded? And they're looking at that? Or am I somebody that's looking at one of those medication administration records of 10 drugs and having to code every single one, like the hour and the thing, like going through every single one because there is no software. So all of that can be more involving for your as a coder. Like I'd rather have the system do it and then me check it than having to do it because it's going to take a lot longer in my processes.
Yeah, I ended up having to do all that up front because I was doing authorizations.
Mm-hmm.
Oh, yeah.
All of that. Mm-hmm. And trying to figure out what is anticipating what is going to be needed, and calculating the milligrams and how many milligrams over like 6 months I would need.
Mm-hmm.
Yeah.
And then the authorization coming back with one.
To add to what the ladies also mentioned about finding policy, so the Medicare website, of course, they have a searchable database. So I usually start typing like complex billing, and then it'll give me all the documents related to like chemotherapy because I don't want to miss anything. But then also knowing who your contractor is for whatever state that you're living in. So you would also go to the contractor's website and just check to see if they have any policies on complex drug delivery or a particular medication.
Yeah, I think like a lot of your like a lot of your Blue Crosses, your Aetnas, your Cignas, they have a list of medications like you need prior authorization before you can even administer it, and it has to be supervised, and there's so many hoops to jump through. So that's another thing. This isn't like something that happens like overnight. Like if you want chemotherapy, you can't just walk in and get it. Like you have to, it has to have planning, and usually that's a good thing because these medications aren't cheap.
Right. And to your point as well, John, there's depending on the facility, they usually have like a dedicated prior auth team, and they have like representatives that will help for free drug programs, because a lot of times patients are not able to pay out of pocket for certain things if it's not covered. So they may fall under like a free drug program where it could help them out, so they could still get the drug that the physician thinks is best, even though the insurance might not cover it.
Or there's such a large out-of-pocket to the patient, that's such a financial burden for them to deal with. But I totally agree. Yeah, like, and as a coder, if you're new into this and you're new in a hemonc, I recommend you job shadow those departments, like get to know, like see where it goes from front to the back. Go go spend a day in the infusion center if you're going to be coding infusions, because what's better way to learn from a nurse, and see how the drug is getting in there and understand what the hoops that they might have to jump through, and just kind of gives you that experience, to be able to code better and be more well-rounded.
Mm-hmm.
All right, so we talked about some of the office procedures. Let's talk about surgeries. Stephanie mentioned MedOnc. Is there like any other branch called SurgeOnc, where they it's only surgeons and they only operate and only put things out and put things back?
Yes. Yeah, again, the surgical oncologists, a lot of times, just in what I deal with, they might come to us and say, we want this patient to be tested for genetics so that they can determine what is the best course of what they want to take out, of what, wherever they want to take it, because based upon the genetics of that patient, is it a genetic issue? Or is it just environment? And, so a lot of people know that genetics, there's like 10% of cancers are made up from genetics, and the other 90% is, other factors. So they might come to us first and say, hey, could you do a genetic workup on this patient before we go ahead and plan the surgical route in the surgical case. But yeah, most of the time they're taking, if it's wherever the cancer is, and making sure they have clear margins and all of that.
And when I mentioned putting things back, I'm talking about when they do transplants. I mean, like putting in a replacement organ that they take right out, and that's just not like, you didn't pay your bill, so we're putting this back in you. No.
Don't put the cancer back in me, thanks.
Well, it's interesting that you mentioned that, because when you think about that, you're thinking about transplants, and I'm thinking about colon cancer, where they may do
fecal reimplantation.
No, well, they may take out part of your intestinal tract, do an ostomy, and then reattach it later. It really just depends on, that's definitely a surgical oncology situation for colon cancer. Transplants, actually, there are a subset of hematology and oncology for bone marrow transplantation. There's an actual subset for specialty for that.
All right, so let's get into other subspecialties. Like we mentioned MedOnc, we mentioned SurgeOnc, we mentioned transplant. What are some other kinds of specialties within hematology oncology that might be something that could be like something that a coder might want to find as their new niche kind of career? They want to be the one that specializes in eyelid cancer. Well, who does that? What is that? I'm sure it's out there.
Probably radiation, as Stephanie had mentioned before. Radiation oncology is another big one. I know there are dedicated coders that look at those type of records, so that could be another little niche that someone might be interested in.
There's actually a certification for radiation oncology separate from the CHONC. It's the Radiation Oncology Certified Coder, the ROC. Also, I was thinking about this, and you've got surgical oncologists, you've got radiation, you've got gynecological oncologists, pediatric oncologists. An interesting fact about pediatric oncologists, they have to be certified in pediatrics as well as oncology, separate. That pediatrics is a really hard part of oncology. And it's interesting because you see a lot of the hematology and, oncology. And I was going to also mention that within the specialties of like MedOnc and GynOnc and RadOnc, people actually specialize even further. Like some may specialize in breast cancer, some may specialize in lung cancer, especially in academic settings. You'll see, because they follow the research, and in academic settings, a lot of them are doing the research, and so they become known for a specific mutation of a cancer. even further. It depends on what that specific provider is interested in and what they feel called to do.
And a lot of them sit on boards as well. So they sit on tumor boards where they have to go present. This is like the breast tumor board or thoracic tumor board, where they're presenting to a whole bunch of doctors in a room, and to come up with the best treatment option. Like, here's my case. What would you, like, let's come up with the best surgical plan of care, or chemotherapy plan of care. Other type of specialties within, like I had mentioned, hospice and palliative care is big, and it's growing, because not only we're finding that there is such a positive impact to providing the supportive care services earlier at the time. Like, again, when a patient gets diagnosed, they don't want to have that conversation then. But there's a lot of things that can help those patients. They have to mitigate so many different side effects and issues when they're going through chemotherapy. So a lot of times, having a provider that you have your oncologist that's working with the cancer drug and working on that piece, but this supportive care doctor that specializes in all the supportive care therapies that are going to help you, whether or not you can't eat, you're unable to eat, and or if you're having issues with diarrhea or constipation or throwing up or all those different things that you might have, that's that supportive care provider. So I know a lot of practices are utilizing that, and having those visits and being able to talk to those patients and counsel them and give them dietary options. A lot of people are adding registered dietitians into their clinical practice. A lot of them are adding mental health, and because what happens when you go through cancer, your family member, your caregiver, you're dealing with a lot of issues. And so again, that supportive care, that's all kind of underneath that. And then what happens when you are completely done with cancer? Let's say you're in that remission, or you're in the survivorship, as we like to call it, window where you're no longer getting treatment, but you don't feel quite confident to go back to your PCP that was treating you before. You want to continue to see an oncologist, or continue to be in that kind of, what are the things, dietary things, the things I can do to reduce my risk to getting cancer again, or to, what are the things that I need to do? And so that's another thing, another specialty that's coming out. And there's not really a name for it. There's just, but it is people that are specializing in reducing risk of the patient's cancer and genetics, and looking at all that loveliness.
All right, so let's talk about your daily routine. Like, what is your day like? I don't know. These are for the ones that actually code on a daily basis. You, Stephanie, and Alexis. So, what do you do from day to day? Like, do you have this routine you follow, or is it just anything that's kind of thrown at you? I want to get a picture of what the expectations are for, like, when you begin your day and when you end your day. Like, what do you do from point A to point B?
Well, in my role, obviously, I don't code every day, because I have, there are people underneath. But what they do, because that's what you guys want to hear about, is the information. So what happens is all of our codes and everything funnels into a practice management system, where we basically, it becomes a ticket, or however you want to call it, but it's a claim, right? That needs to be reviewed. Has a lot of codes on it. They all kind of, the system just kind of throws it. You got labs on there. You got maybe a office visit, maybe a procedure, maybe the administration codes. And so a lot of times what they'll do is they'll work on that day. So if you're the coder and you're working on Tuesday, you're going to go through Tuesday's visit list, and you're going to look and see, do I have all my patients? Here's my patient number one. And then I'm going to go compare that to the medication administration record. Did I get all the administration charges? Did all the drugs come down on that claim? Can I tick it all off the box? Like, it's all gotten on there. Because that's the first thing, right? Making sure you captured all your charges for that day, for that patient, for that moment. So all the coders, that's what they're doing. They're going through every day. They go through the list. They have, it's a lot of comparing records, right? You have to go and look at the records. If it's E&M, they might have to go look at an E&M and verify. Make sure that procedure was the procedure in the E&M the same day. I got to go look at that. Was there a reason why they had the E&M and procedure same day? So again, just going through that process of reviewing the documentation, looking and seeing if we've got everything. Then it's a matter of them going through and adding modifiers, verifying diagnoses, making sure that they link the right diagnoses, you know, because we do CMS 1500 forms. So they're going to do that one, you know, like making sure the primary, secondary, tertiary diagnosis, how are they linking those ICD-10s on the claim, patients here for chemo or immunotherapy, they're going to put that Z code first. So all that stuff they're going to make sure is all set before they finally get to approve it. And actually send it out the door and hopefully get paid for it. So that's the process of, in a nutshell, of what they do in my office.
How about you, Alexis? You guys do anything differently at your office, or is it kind of all uniform?
Well, so right now, John, I'm working in provider education, but when I was coding hematology, oncology more on a daily basis, this flow that Stephanie described is pretty much exactly what goes on. So if the department has a certain amount of folks that they see the day prior, and it depends on how many days out your department is and how many coders are working these cases. So you would typically get like a large printout of the day prior, and that would be divvied up between however many coders is assigned to that work queue. And based on the printout from the medication administration report, we would go in, look at what was done, how long the medications ran, and then assign the appropriate administration codes for those. If there's any procedures, making sure that the modifiers are attached. If there's an office visit, that was done as well. And then if you're working in Epic and you have the privilege to not have to do too much work, you could just put a few clicks and hit your diagnoses and accept the report so that it can go out to bill. So it really does depend, like Stephanie said, on what system that you're working in. A lot of these new systems are really sophisticated, and especially with infusion and like oncology codes, hematology codes, because they are so high dollar, their effort is to have like very low error rate. So a claim that's holding up in a work queue because of a missing stop time or doesn't have a provided signature or the nurse didn't close it out, like these are small issues that obviously the system or the facility will want to avoid because the charges need to go out the door. Right. So it depends on what system that you're working in, but pretty much it kind of is the same. A very long report. And then hopefully a really good team to be able to share what came in the day prior or however far out you guys are. And another thing that people are probably surprised by is how many appointments are seen in hematology oncology. Because like one day prior could be over 300 cases. Oh, yeah. So it depends how large the services are, how large the facility or the clinic is. And they can get really long because the infusions, they run for hours. So yeah, just having that workflow in place with the other coders on the team kind of balances things out.
Okay. Now, you also mentioned when they have like when they have routine administration. So one of the things that I always thought was wild was where when the insurance company pays for it, it has to be administered by the provider. But a patient might actually not be supplied, or that office might not supply medication. So sometimes the patient brings it in to the office and says, "Hey, can you inject this into me?" So like with these high cost medications that could cost like $500 one dose or $1,000 and up, you want to know who brought in the medication. Was it supplied by the office? Was it supplied by the patient? Did we find it at the corner store? Who gets the bill for that? And that's something that I see a lot.
There's a whole thing. It's called there's a white bagging, brown bagging, clear bagging. Those are all different ways that you can get the injection, like the medication. So there's definitely there's lots of different, though the white bagging is when the specialty pharmacy sends it to the office, like to be injected. So they call it white bagging. Brown bagging is when the patient brings it in. And again, you can't rely, unfortunately, we don't accept any brown bagging in our office because of the risks associated. Because if we have to inject that drug, do you know that, the patient had it refrigerated at the right temperature or whatever it had to be? And do you want to take the risk of possibly harming that patient because you don't know where the drug how long they've had it, or where it's been, or if it was left out in their mailbox for too long, who knows? So that's called brown bagging. And then clear bagging is when it's dispensed from your own specialty pharmacy. So again, not through like if you think of it, like not billed to the insurance, but through pharmacy, like instead, like your pharmacy, what's the word I'm trying to think of? Yeah, in-house, so it's so those are the three types that you can get. And of course, other than that, it's just the buy and bill, which the practices usually do buy and bill for the drug. They buy the drug and then they bill for it. But more and more drugs, again, that if they're getting free drug, a lot of our patients, if they're getting a free drug from the pharmaceutical company, which because again, based on income guidelines and things like that, the company might again send that medication. If it's an infusion, they might send that, or injection, they'll send it right to the oncologist practice so that we can give it. And there's tracking numbers. You have to give it to that right patient. You can't give it to any other patient. It's for that patient, again, for that free drug that's going to be administered in the office. So you're right. You're going to have to know, like, where is this drug coming from, and how do I need it? How do I code for it? Am I billing for the drug, or is the patient, is it coming from some place that it's already been billed and the patient's already had to pay? So be aware of.
A lot of times also from a coding perspective, we'll see edits in the system. So there'll be flags on a particular patient's name just to let us know that they had a specialty pharmacy or they had a white bag. So that's always something just to pay attention to, so that the drug code doesn't go out on the claim if it doesn't need to.
And the good news is, like your local MAC, a lot of times they're going to cover that drug administration, even if it is still free. So it's important that you bill for it, but you might have to put a penny charge in there for it or something to that, again, refer to your local, your insurances, the payers out there. But understanding that you can get paid for that administration, you are doing that work, you should be paid for it, even if you didn't supply the drug. But understanding the limitations of that is important too. Read the guidelines, read the things online that you find from CMS, from your local Medicare administrative contractors.
Yeah, because the insurance companies, if you just put the administration on, they're like, wait, but what are you?
What reason? Yeah.
What's it linked to?
Mm-hmm.
Yeah.
What's
And also, if a patient comes in only for the inject, and you can't bill for the inject, you also can't bill for the E&M because there was no E&M. It's just the injection. Patients walk in, stab with the needle, and they go home, and the provider doesn't bill anything. Doesn't sound like, reasonable. So yeah, you can bill for the inject, and I think what I've seen is, like, you put a claim line, injected, 50 milligrams of Fasenra or whatever, or Prolia, and you just mark it in claim note. Hopefully that's enough. It all depends on your payer, I think, right? I mean,
yeah, some allow a different, again, just having that information on the claim somewhere that shows that this drug was supplied. And that you'll get that a lot too if you're working in any sort of research facility. If you're working for a facility that does research, you got to learn how to bill for research. There's a whole for clinical trial billing when patients in a clinical trial, because there's things that you can't bill for and you can bill for and you shouldn't bill for. So you got to make sure no double billing.
And who covers what?
Yes.
Yeah.
And how to read those things. The actual the research. So it definitely can be difficult. But another thing, too, for coders to be aware of, a lot of times companies out there will have edits. We talked about the edits in the front end, like, you have flags, but there's actually edits also in the back end to prevent billing incorrectly. That we have lots of edits within our system, like claims edits, that will make sure that, like this drug with this admin doesn't jive. We don't bill that together, like that should fail an edit, and somebody needs to look at that. A coder might miss that information. So there's a lot of times that will be your double check that it's coded appropriately, or a diagnosis. Sorry, go ahead.
It's your scrubbing edits.
Yeah.
So that it prevents it assists coders so that the chances of it being a clean claim are higher.
Yeah. So if your patient comes in for something simple like a B12 injection, and they're not billing the chemotherapy administration code with the B12 code, because someone's going to catch on to that real quick.
Mm-hmm. I think what's also important to know when you are coding, there are different rules. Like manufacturers will tell you, well, you could use this code and this code. So then you have to determine, well, which of these two administration codes am I going to be billing for this drug? And that could be difficult to know. And so a lot of times it's having conversations with your pharmacy or pharmacist and understanding, okay, is that a highly complex biologic drug, or is that a therapeutic drug? Like where does that kind of fall between? So a lot of drugs out there are kind of, there have been some fall betweens, right? That you're giving it for cancer, but it may not, like the manufacturer's like, you can use both codes, and depends on your carrier. And so you have to do a lot of research. Is it right?
All right. So let's talk expectations. What are some expectations for employees in regards to their skills and their knowledge before they even want to pursue hematology and oncology? And what kind of mindset does this coder have to have or concerning? Because I think that's important with this especially kind of specifically.
Someone needs to be detail oriented, extremely detail oriented, curious, persistent, and open to researching. When I was in the clinic, I did a lot of research. That's part of how I grew and got known in the industry, was researching on my own, taking initiative, and going out there. If I didn't know something, I was researching it and learning about it. And I ended up becoming subject matter, an advisor on like policy and oncology, because I did that. It takes someone who will take the initiative to do that.
Mm-hmm. I would also add someone who's organized and kind of systematic in their work. The specialty itself could be overwhelming. I mean, we are reading charts where patients have very chronic illnesses, are very sick. So it could be overwhelming, but just making sure that you're organized in your day-to-day flow, I think, is a really good skill set. And I would agree with Rachel, being curious. We were talking earlier about like a lot of the stages that we would see in the record and just the different terminology. So that's going to pique your interest initially too. Like, what does this mean? What kind of tumor is that? What kind of marker is that? And there are additional ICD-10 codes that you can tack on to a patient's claim depending on, what the provider documented. So being curious, being detailed, and really being organized in your work, I would agree.
Yeah, I fully agree with what they said. I mean, definitely ask the questions too. Don't be afraid to ask questions. That's when I'm looking for, and I'm hiring, I want people that are going to ask the questions and not just sit there and be like, okay, I think I know everything. I'm like, there's no way you're going to know everything. You're going to come in. So like you said, being curious, asking questions, go check out all those resources that are available to you. Start reading about the different drugs and brands and understand how that whole work. But following a case, I think it does get hard reading some of the cases. I mean, I audit the physicians, and I look through their notes, and it's sad when, like you read some of the cases when they're metastatic into not just one place, but several places, and they're still alive. And you're like, this person has beat this and has beat this and has beat, and you're like, how do they, so they're still doing great, like they're still living. And so some can be very inspiring, some can be sad, because you treat the patient like, if you're a coder and you're constantly coding this patient, then one day you're not coding them anymore. And that's hard sometimes, because you get to know their treatments, and you get to know the patients, and especially if you're working in a smaller clinic, it could be more intimate and knowing those patients. So it does get hard.
I mean, I can see that. Like you see this patient comes in routinely every day for or every 2 weeks, like on the mark, and then you realize I haven't coded in a while. Like, and you have asked that, what happened to Jane Doe, and then somebody has to tell you, oh my God, you didn't hear? She moved to Connecticut. No, I'm sorry, I didn't mean to joke, but like that happened.
We've had some of those.
And like, depending on the EMR, it'll actually tell you. Unfortunately, it'll pop up when you first open it. It'll say, the patient is deceased. Are you sure you want to add charges on this record? So depending on the kind of system that it is, it will alert you, which is sad, because if you've seen that patient on your list prior, and then you're like, oh, wow.
And they were trying so hard. They were trying to give them the treatment. And a lot of times, you just don't know that this patient's, going downhill so quickly, and that's hard. And a lot of times I also recommend, getting involved, with different societies around, learn about, like there's lots of different things that raise money and raise awareness and research, but also just in your community. And what can you do? There's a lot, like we have issues with food insecurity in our state of Maine. I mean, it's food insecurity is big. So I recently went to a foundation where they were raising money for, again, some gift cards to go to your grocery store, because you shouldn't have to choose between your chemotherapy medication and how to get that food on your table for your kid or for yourself, and to eat healthy. So I think that's important. And just learning about that stuff, go and, be open to, as, just because you're coding, you might be working from home, you should still get out there and learn about these things, learn about your patients, and that you are coding. And that there are diagnosis codes for that too. So.
Stephanie, that's interesting that you said that, because earlier in my career, I actually got involved with a lung cancer group, because I've had several family members, and learning about it and learning about that process actually made me a stronger coder, because I learned more. I knew about the anatomy, but learned more about the anatomy, and being able to talk about it to other people helped me with my own career. So I highly agree with what Stephanie said. It also helps you be more open, and more open to the industry as well. You learn, you network more.
Yeah.
You come into contact with more people, and it opens your eyes to things.
Mm-hmm. Definitely.
So we touched on the fact that this is a very kind of a sensitive topic, and I don't mean to be insensitive, but like this is something that you really want to think about when you're reading these notes. Some of them can be really heartbreakingly sad. Is this something that you're going to be able to handle if you want to do this? I mean, me personally, I'm a crier. I don't think I could do it. I worked for about 3 months doing pediatric cardiothoracic surgery for a while, and I got wrangled into doing pediatric hospice. Never again. Like, do you guys see that? Like, you guys see some of the notes are so intensely descriptive that you just you have to put one down, just, make balloon animals, something to bring your spirits up. Do you guys see that a lot? Because I've had it in charts.
So I would say yes and no. So in all of my time in revenue cycle at all, I have spent all but 6 months in oncology. And I got pretty good at compartmentalizing. A lot of times you have to look at it as it's a name on a chart. You're looking at numbers, you're looking at words, and you're abstracting, right? You're basically pulling out the information. But there are cases, especially the ones that you have to actually talk to the patient on a regular basis. I was in a clinic where the infusion suite was 2 doors away from my office area. So, and I was having to call the patients about authorizations. So some of those cases really got to me. I've just been very fortunate that the practices that I worked in, we were very close knit. And we became almost like family. And I've found this to be pretty true with a lot of oncology. Particularly because you are seeing a lot of more of the sensitive cases. And so we really, we shared in the triumph, we all shared in the triumphs, and we all supported one another in those valleys. So it really, it's good to have a very good support network if you are in this specialty.
100% agree.
How about you, Stephanie, or Alexis? Have you had any heartbreakingly sad things that you've had to deal with, and how do you handle it?
I think when you get those alerts, like I said, when you open a chart and a patient who you have seen before is no longer living, that is definitely hard. But I agree with Rachel about just putting certain things in their box. Overall, we are doing a job, so we do have to finish out our assignments. In a sense, we just have to find a way to read the medical record and then apply the codes and kind of keep going. It's also difficult too because we're not, depending on the role that you have, we're not facing with the patient. So we're kind of reading a story, almost like reading a book, because you kind of see all the history that the provider has put in their notes. Mm-hmm. So if you want to deep dive, you definitely can. But if you want to stick to getting in the chart, getting the information you need, and then just moving on, that could also be a way to kind of keep your head in the game and not just get too lost in the sadness of it all.
Yeah, I agree. And a lot of times it's mostly written in the E&Ms, so depending on if you're really reviewing that, you're probably not going to be you're just going to see diagnoses, you're going to see codes, you're going to look at times, you're going to look at milligrams, you're going to look at units. You're not really going to be reading the story unless all you're doing is E&M coding. If you're doing E&M coding, then you are reading the story every day. So you will have to compartmentalize, like Rachel says, you will have to put them in a box. And that can be tough. So again, if looking at that, I find every time I'm auditing, there's always a sad story, but you got to take the wins, you got to take the losses. I think one of the most inspiring things that I can really think about is the new drugs that are available, the new things that, it wasn't working and the patient was going down, and there was a new drug that came to the market or new way of doing something. And if I can be supportive or help with bringing that into the practice as far as how do we code for that. Like there's a new one with bispecifics is a big one, right? So bispecifics is huge, and we're trying to it's a type of drug that's being given based upon how it's given, but it's there could be a lot of side effects to it. But the good news is that this is if they didn't get it, they probably would die, unfortunately. And if we were able to offer it and at the convenience of a patient being able to do it at home as opposed to going to the hospital for 4 to 5 days, just think about how you're helping that patient, and that can be rewarding. And that's what I take on those rewards. I'm helping this patient. I don't know this patient, but I'm helping them get the treatment that they need and they deserve and that they should be getting, but in the convenience of being able to do it near their home or at their home. So.
And even though most of our function is probably like revenue cycle focused, it does give you a sense of reward that you're helping in some small way. Like we're submitting the claim, we're adding codes, we know that we're doing our part. So it does feel rewarding in a sense that we're able to help, even if it's on the back end of the financial office and no one even knows. Well, the patient rather, they would never know, but it gives you that sense of reward in a way.
That's actually something that I've brought up in presentations before. In general, revenue cycle and employees in revenue cycle I wouldn't say it's thankless because, a lot of our providers understand exactly what we bring to the table, but the patients never see us. We don't really talk. But the thing is we are one of our patients' biggest financial advocates, because a lot of times these patients don't understand their insurance, they don't understand the financial picture, but we do. And we're able to we are on the front lines, but we're on the front lines with that insurance company or with the claim. So while we may not see ourselves as that, we are financial advocates for our patients.
We're their cheerleaders.
Yes, absolutely. And sometimes we're able to actually explain to them that, this is exactly what you're seeing, because they don't understand it. And we're able to bring that to the table.
And there are drugs out there that, unfortunately, you have to have those conversations. I mean, I've gone right to judicial reviews on some things that you have to, you and your pharmacist have to go there and say, this is why the patient had to get this drug. It was off label, but here's the reasons why. And I'm not a doctor, but I know how to code it, and I can help, again, have them understand that, to try to, again, to get a claim overturned, to be paid. And I think it's rewarding when that happens, and you can see that for that patient, you were able to get something paid for them, and they're thankful for that, because they didn't, again, they didn't have to absorb that cost.
And those triumphs feel so good.
Yes, they do.
You guys ever get to hear about any patients that were able to ring the bell? Like I've seen it all the time with like when they're cancer free and they ring the bell. Do you guys ever see that in charts, or is that something that you can look forward to? And when you see that,
I've been asked to be at patients' bell ringing before, just because of some of the work that I've done, or I happened to be in the infusion suite walking through at the time, and they want to celebrate with everyone, because it's a big accomplishment. That's a big milestone. It's sometimes kind of a double-edged sword, because you have other people in the infusion suite who are still receiving treatment.
Yeah, they're not there yet.
And they may never be there.
Right.
But it also gives not only them hope, but it gives us hope for what we're doing.
Definitely. Yeah, we have a bell in our treatment room as well, that was installed by a patient that asked to put it up, and, again, that was going through the treatment. But you're right, it's hard for those patients that are still going through it, and I've only seen it once happen, but where they ring the bell. But it is, it's important to celebrate those milestones, but also to be cognizant of the other patients that are still battling.
All right, so I just got two more questions before we can wrap up tonight. We've been here an hour and 15 minutes, but once a coder masters the core fundamentals of heme coding and claim submission, what's the next step in their development? Like, what can they do if they want to advance?
I'll start. I think auditing is probably the next natural step. When I was doing day-to-day infusion coding and in the hematology oncology area, that was what I looked to do next. I went ahead and got my CPMA after being CPC for a while and then CHONC for a while. I think auditing is great in the sense that there's a lot of complex things going on. When we look at medical administration records and office notes, auditing E&M, of course, there's going to be endless areas for a coder to get into that space, but also on the procedural side. And depending on the department that you're in or the facility that you're in, it may be a natural progression. You may not have to get another certification to do so. If your senior leadership sees that quality within you, they'll appoint you to like start looking at some records, which is kind of what happened with me when I was first interested in auditing. So I like educating. So even just with my peers being able to share, okay, I think it should have been coded this way or that way, I think that's probably the most natural progression from this role. It's probably into auditing.
I agree. I was going to say the same thing, auditing. But another thing is, I always hear is you can always join the dark side, which is the insurance side, and go to that end, and because you have knowledge of working at a facility or a community practice and coding, they need people like that, right? That are looking at, there's so many audits out there that are looking at single dose vial audits, so that they're drug focused, right? Looking at these drugs because they're, again, high cost, but they're, how are they being administered? Are they being administered correctly? Are they following the procedures per the FDA guidelines? Are they putting the right modifiers? Are they putting the right units? Making sure that they're giving the smallest vial size available. All that stuff is really important. So again, if you're if you wanted to go to the dark side up to insurance payers, I heard there's a lot, or even just I think I heard about payers that there's, they have those SIU audits that they're looking at, there's lots of different areas. So you're not just pigeonholed into, I'm only going to code for a facility or an oncology practice. You got to, you think outside the box. There's lots of different things that people are looking at, and you could potentially go and expand your horizons in.
Yeah.
So I would definitely agree with the auditing. I always advocate for coding and billing to go together. I believe that a coder with a billing background would be very strong employee, vice versa. It goes hand in hand. So billing, especially in oncology, because there are so many different policies that apply in here, billing is a lateral move, but it also makes you a stronger coder as well.
Definitely.
How about if you're working in like one of these niche areas, like say urology or urogynecology? Would you recommend maybe taking a certification in either one of those two areas, or kind of specializing in like orthopedics or maybe neurology? I know there's not a lot of cardiology cancers. There's I've only seen one out there, but I'm sure there's other roles you can take if you learn enough about one specific area. You can kind of
Isn't there an ambulatory surgery certification?
Yeah, there's the
and you would see that a lot with surgical oncology.
Mm-hmm. Yeah. And also think about, there's, they can learn more about the research side of things. So maybe they want to go into work research. I know a few people that left and worked for a pharmaceutical company, and just educating the at the pharmaceutical levels, educating the providers on the drugs, Yes. So that's something, because again, a lot of these pharmaceutical companies need help because they don't know the coding and billing guidelines for a new drug coming to market, and how to educate lots of different providers across the country that are going to give this drug. So that's another opportunity.
And tumor registry.
Yeah.
Yep. That's another one. Yep.
And I will tell you, most registrars, once you get in there, they are in there. They're not going anywhere.
Oh yeah.
They're not going to go anywhere until they retire.
Yeah, they retire doing that.
Yeah. So lots.
I
I
think
think there's
that's
lots
like
of growth.
such a small niche that a lot of people don't know about. They have their own set of credentials as well, and they can work independently also. Yeah, so that's a really great option as well. Tumor registry.
I didn't even think of that.
Yep.
That's a good point. Last question. So, what are some resources coders can use now to learn or improve their skills in being successful in heme coding?
So I will tell you, when I researched everything, I just went and I Googled everything, because I actually started in radiation oncology, and then because of a practice buyout, got thrown into medical oncology, and I got handed a little PowerPoint about infusion coding, and I was like, "What did I just get into?" And I ended up loving it. But looking at, there's a ton of PowerPoints online about infusion coding. One caveat to that is the infusion codes were updated around, I should know this. I really should know this. I believe about 2015. That might be the therapeutic, but around 2015, 2017. So to pay attention to the PowerPoints that are online and make sure that they are applicable to the current codes. And that's for any kind of research that you do. Make sure that it's applicable, because codes change all the time, all the time. So go in. There's stuff online with AAPC and other on infusion coding. Do look into that. There's resources online with specialty societies, with but go and look. Go take the initiative, because you're going to need that for when you get into oncology. Take the initiative and do the research just to get a basis on what you may be seeing.
Yeah.
How about you, Alexis? Any ideas on what a coder can do now if they're interested in learning hematology and oncology?
I agree with what Rachel said. I would just do a deep dive. There's a lot of resources too on Medicare, as I mentioned earlier. There's a lot of articles on Medicare. Even the retired ones, they're retired, but they're just good to look at sometimes. Certain states have retired their drug policies for whatever reason, but they may be active in another state. So it's kind of just nice to see what is required and which is out there in the universe. I would definitely also keep maybe a spreadsheet of just different information that I find, so it could be easy to reference if you did end up moving into a role like this. Medications is just always like chemo medications. There's a chemotherapy.org, and they list like all sorts of different medication. They index different things. It's just good to get an idea of the kind of names that you'll be seeing on a day-to-day basis. And then for diagnosis coding, reading your guidelines, that's always some place to start. Familiarizing yourself with the cancer chapters and the guidelines surrounding what can be coded in what setting, what's primary, what's not. And I would just kind of immerse myself in the information that's available to me now. So also too, that could set up a great segue for an interview. If somebody's just looking for whatever reason to get into hematology, oncology, or they want an infusion code, having that kind of conversations or in an interview, I've already started doing a lot of research. I'm kind of familiar with this specialty. That really adds to your chances of standing out during the interview process.
How about you, Stephanie? Any upcoming, I don't know, webinars or something that could be a good resource for somebody that wants to learn about drug infusions or something like that, or anything that you can think of?
Yeah, definitely. I'm presenting at HealthCon coming up next week. I will be presenting on "Don't Gamble When Coding Drug Waste." So if you are headed to HealthCon, or if you're going to be attending virtually, please check out my presentation, which is all about drugs, all about the drug coding, which is, like Alexis had said, it's a whole other gamut. And just there's there's a lot of involved with that. So a lot of your local chapters too will get speakers like me, and Rachel, you've spoken at chapters, and now Alexia, I'm sure you have too. Like they'll come, we can come to the chapter and talk about infusion coding. That's a great resource, again, just to hear it from somebody that's doing it. Look at their slides, review the slides that they're going through, review the examples. Go check out Chonk. If you're not a Chonk yet and you want to just get the study guide just to kind of familiarize with a lot of these terminology stuff that we're talking about. That's, again, I don't want to say a cheap version, but a cheap version to get everything kind of like, all hematology, oncology in one. They also have a lot of resources. I do know AAPC does put out like guides specifically to have in oncology and hematology. So it is worth checking that out, see what they have online, what free resources you can find, available to you. NCCN is another great place. The National Coding, National, hold on, what is it? Chemo, I can't think of the name. What does NCCN stand for?
Cancer.
Comprehensive Cancer Network.
Yes, there you go.
There's so many acronyms, as we know, with but NCCN does, the nice thing about that is if you do have, again, you can go on their drug compendia, you can look at all the different drugs, the different, like let's say they're giving this one drug and what are the ICD-10 codes that it's like they put everything mashed together from the FDA. Here are the diagnoses, here is the drugs, here is the what they have to, is a first line, second line, all that stuff. So a lot of times, if you're working in oncology, see if your office, has a subscription to it, so that you can be part of that subscription, and so that you can relearn that stuff right there. A lot of times that's good for the financial advocates because they use that for getting those prior authorizations or trying to get the drug authorization. So they'll go in there and make sure, do I have the right diagnosis for the right treatment? Is this the first line, second line? So they're going to be looking at that. But nccn.org is definitely a good place to go for anything that's cancer related. Diagnoses and drugs. But there's so many different drugs out there. They're always coming out with new ones. I'm constantly getting emails. Here's another drug we're giving in the clinic. Okay. So guess what I do? What do you think I do? I do research. Every single time a new drug comes on, I'm going to the manufacturer's website. I'm going to FDA website. I'm looking to see all this stuff. That's what we have to do. Being a coder is looking at all these different things. Being an auditor, this is all part of that. It's just digging under the hood and seeing what's out there. So yes, so there's lots of resources, and feel free to network with us. I think that's a big thing. We're, get in touch with us on LinkedIn, and if you're in HealthCon, come see me. I'd love to talk to you about this. Even if you're never done before and you're like, hey, I'm interested. There's so many great people in the industry, and once you start meeting them, it's going to expand your horizons for not just oncology, but anything out there. Networking is the best for just learning, like, what did John do? Well, he's my you're allowed to go GU and cardiac. So I know I can talk to him about that stuff. So it's just, I think that's important. Mm-hmm. Network.
So any last minute comments you want to give, or any kind of whips of snips, or any snippets of wisdom? I had that backwards. To any upcoming hem-onc coders out there.
I would say it's not as intimidating as it might seem. I think it's a really good specialty to start out in as well, because it was the first specialty I started out with when I first got my CPC. And to come off the hills of a CPC and you're already so thirsty for information, you're really energetic about the field, you're ready to just dive in. This is a good specialty because it really piques your interest. Like, you're going to see things in medical records that you had no idea about: trials, drugs, new treatments. The physician language is something that you'll get accustomed to as well. So I think it's not as intimidating as it seems. It just takes a little tenacity. And I think it's a great way to start out as a new coder.
I'd echo that simply because you can't, like we said earlier, cancer can happen anywhere. It runs the gamut throughout the body. So you really get to know what you enjoy, and what piques your interest. It's not, I wouldn't say it's as overwhelming either. But then again, it's all I've done. Um, and you find, regardless of where you end up in your coding journey, you find your passion. Um, and that's where you will see your success. There are people out there who say, oh, I just, I don't want to go to work today. If you find where you are passionate at, it's kind of cliche, but you enjoy your work, and I still work, but I enjoy it. It's what I, as my husband say, I nerd out on it.
I love that.
And how about you, Stephanie? Any last minute?
Yeah, I mean, to echo what they said, definitely it's something that you have to have passion for. I think cancer affects so many people, but we all can take a little bit to heart of everything that we do in any kind of case, whether it's cancer or any kind of specialty. But I think with this, there are so many nuances there. There's so many nuances on oncology coding or hematology coding, and ultimately, I mean, we all want that cancer drug that for everybody that will be 100% and nobody, everybody's in remission after that, and the cure is out there. But in the meantime, this is what we have, and I think, my dad's going through chemotherapy right now, and it's just for somebody that has worked in this in 20 plus years. And now I'm having to be the caregiver with my family. It's a little eye opening, on that other side. But I feel like I'm a little bit of a translator. So I'm helping them navigate, the world of drugs and how they can, again, what's the drug that they're going to get, how they're going to get it. And you just got to stay curious, learn.
Yes, oncology is ever evolving. It's always changing, and there's always something to learn.
Yeah. If you just want to do the same thing every day, then it's probably not for you. Because it's probably not your cup of tea. If you're just like, I want to do this and that's it, then probably not. But if you're looking for just growth, and there's just so many growth opportunities. I think we went through a lot of different growth opportunities within medical oncology and hematology. So
Isn't that what neoplasm is? It's a growth.
Yeah. Yes.
Tumor growth. Yes.
All right. Well, I'd like to thank the three of you for joining us tonight. And as always, we do these presentations because we like to network with people and get you a chance to experience what it is and talk to the experts. So another thing that me and Caitlin Brack have been doing is we want to start this new process. If you're a coder that wants to learn any specialty, put on your LinkedIn profile, put on your official profile, hashtag mentor or mentee, and that specialty. So if you're a mentor and is able to take on a mentee and wants to offer advice, guidance, we got to find a way to put this in your LinkedIn where it's easily searchable. And if anybody knows how to do this the right way, I want to make sure this is successful and this is something we can get off the ground. But it's a way to connect mentees and mentors. There is Mentor City with the APC, but sometimes people don't use that. So LinkedIn is more prevalent. And if you want to try this process, it's something that we want to kind of initiate, and you can ask questions about, or if you want to put on your page and as a way to kind of put yourself out there as I want to learn hematology or I want to learn oncology. This is the way to identify yourself on LinkedIn. And if you are still interested and this coding talk has got you really serious about coding and you want to learn more, Blue Garcia is live right now on our LinkedIn page talking about coding opportunities for people with no experience. So if you're able to go to her YouTube channel, her name is Blue Garcia. Blue is spelled BLEU Garcia. She's hosting a presentation right now, and we're already a little over, so it's already begun. So after this, you just go and click and join her. Shameless plugs. But again, hematology, very important topic, very there's a high need. There's a lot of openings for hematology and oncology. So if get yourself learn in that specialty, and you're almost guaranteed work. All right.
Yes.
Thank you all for joining us, and hopefully within the next week or so, I'm gonna do another presentation on cardiothoracic and cardiovascular coding. Hopefully soon. So hope to see you then. Good night, everyone.
So much.
Thank you.
Thank you.
Bye, guys.
Bye.